record for us. Thank you. Great. Well, good afternoon, everyone. I'm Gary Harbison. I'm the Executive Director of the Missouri Coalition for Oral Health. And you just heard that we're recording this, and the recording will be available later on our website or on the main page, right where you may have seen the registration information on the main page. And in fact, recordings for the other webinars we've done this month are out there. I want to be sure to thank the Missouri Department of Health and Senior Services Office of Dental Health for sponsoring this webinar and the 3 other webinars we have done this month in this series. Please see the website for more information, as I just referenced, and that's oralhealthmissouri.org. Pretty easy to find. I also want to thank the Missouri Primary Care Association and Karen Dent for providing CEUs for dental professionals, and thanks to the Missouri Department of Natural Resources for CEs for water operators. Please watch for a post-webinar survey and complete it. And if you don't see one pretty quickly, check your spam folder. We do have issues with our generic info account showing up in people's spam. And you could certainly email us if it doesn't show up at all. Probably get a few reminders for that. I want to thank our speakers before we start for sharing their expertise and experience and taking time out of what are very busy schedules to be here. We have 50 people registered. I want to thank each and every one of you for being here today. And just a pragmatic thing, we'll be using the chat feature for questions, and we'll do our best to get to all of the questions. So we ask that you use the chat feature. If you have a question, just pop it in there. The Coalition is a nonprofit agency dedicated to improving Missouri oral health. We are a small but powerful agency. We have members located throughout the state, and we all work together to meet the many oral health challenges of Missouri. We are supported by membership donations, the Health Forward Foundation, the Missouri Foundation for Health, and the Missouri Department of Health and Senior Services. Most available numbers indicate that Missouri has many oral health challenges. Rural areas are particularly hard hit and often have limited or even no access to dental care. And access is an issue in many of the suburban and urban areas of the state as well. Members of minority communities and those with limited and low income have difficulty getting care. Missouri, in fact, has pronounced health disparities. The Coalition works to achieve health equity by focusing on an often overlooked public health issue, oral health. Maintaining good oral health is essential to overall health. Poor oral health interferes with work and school, and it can lead to death in worst case scenarios. Local decision-making bodies determine if public water systems are fluoridated. So that is important to recognize that is very much a local decision in the state, or some people refer to it as home rule. Factually, though, properly regulated community water fluoridation is one of the most fair and equitable ways of maintaining oral health. Fluoridated water is available to all members of the community, and communities without fluoridation have higher rates of cavities, and that's particularly difficult in rural areas where they have so much trouble accessing dental care, and in many cases can't afford to do it. You will find more information on the Coalition website and on the Department of Health and Senior Services website. Just search Missouri Oral Health and you should be able to find both of those. So with that brief introduction, I want to introduce Ashley Herman, who is going to introduce our speakers. She is the Community Outreach and Project Development Director with the Coalition. So Ashley, you have the floor.
Thanks, Gary, and thanks for that introduction and overview of the Coalition. We have 2 wonderful speakers for our webinar today. The first of which is Tracy Beamer, and she is a fluoridation engineer with the Division of Oral Health at the Centers for Disease Control and Prevention. So Tracy, if you want to go ahead and turn your slides on, you may share your screen.
All right, thank you, Ashley. Thank you, Gary. Let's see. confirm, can you all see my screen? Yes, you can.
We're good.
Let me make sure I have this up. And I need to move you. All right, I think I'm all situated. All right. Hi, everyone, and thank you again for that introduction. And I want to start by thanking the Missouri Coalition for Oral Health for putting together this great webinar series, and also for inviting me to be part of the discussion. I know from working with the folks in the Missouri Department of Health that Missouri has really made some great progress with their fluoridation program over the past few years. So a big shout out to Gwen, who is following me in this presentation, and her colleagues. Also, I want to thank everyone for listening in today, especially the water operators and staff. You really are the public health heroes, providing both safe and healthy drinking water to all your customers. My presentation focuses on the water fluoridation activities that we perform at the federal level at CDC. And then we'll move into some best practices for safe and effective operation and maintenance of different water fluoridation systems. So it'll get a little bit more technical in the second half of my presentation. All right, so community water fluoridation sits within the Division of Oral Health and the National Center for Chronic Disease Prevention and Promotion at CDC. It is one of two of the effective oral health interventions that we administer and track, along with our school-based dental sealant program. We also cover a wide variety of dental and oral health topics, including infection prevention and control in dental settings, which obviously has been in the forefront during the last year and a half during COVID-19. In general, and this goes with state programs as well, community water fluoridation can many times be a bit of the odd duck based on the cross-cutting involvement of both dental or oral health and drinking water programs. Of course, community water fluoridation makes sense in oral health programs from a health promotion perspective because of the clear health benefits, but also can be a bit challenging due to the heavy coordination needed with the straight drinking water programs as well. From state to state, where community water fluoridation is administered can vary. For instance, which you all probably might know, in Missouri, water fluoridation sits within the Department of Health and Senior Services, while your drinking water section is under the Department of Natural Resources. While some other states might have both the oral health and drinking water sections found within the Department of Health. All right, so the Division of Oral Health at CDC also provides oral health program support. We provide funding to oral health programs through a cooperative agreement to 20 states and 1 territory. This current funding cycle is through August 2023. And as you can see, Missouri is one of these 20 states. One main component of this funding is community water fluoridation. The funding includes requirements for data collection and reporting, training, equipment inventory, among many other requirements. But the ultimate goal of the funding is to increase the population on community water systems receiving optimally fluoridated water in the state over the funding period. All right, so this is just a brief slide to highlight some of the resources that we provide on community water fluoridation, including the oral health and community and cost benefits. So for the water operators and staff on the phone, I think probably one of the main items that you are probably confronted with is the question of whether the operation and cost of fluoridating is worth it. So I'd like to continue to highlight this infographic on the right as it shows both the economic savings and the oral health benefits. So as you can see, as highlighted in the graphic, economic analyses show that for every $1 spent on community water fluoridation by a community, so this is the cost of installation, operation, and maintenance of the water system, the return is approximately $20 for both the community and families in averted dental costs. And this is estimated to save $6.5 billion nationwide. So just kind of some basics on water fluoridation. I know that a lot of you are probably familiar, but I want to make sure it gets covered for any listening in to the webinar that might be new or just learning. Fluoride is naturally occurring in all water sources. Surface waters typically have low levels, while groundwater can have natural levels of up to over 10 milligrams per liter. Missouri actually has quite a few water systems with natural fluoride levels, which we classify as over 0.6 milligrams per liter. Based on the data in our water fluoridation database, Missouri has actually over 100 water systems receiving optimally fluoridated water from natural sources. And when we talk about community water fluoridation typically, and what the focus is for most of this presentation, we are talking about water systems that increase the fluoride level in the water for oral health benefits. So more specifically, it's the fluoride added to the natural source water to achieve the recommended level of 0.7 milligrams per liter. I just want to reiterate that CDC's position on water fluoridation is that fluoride in drinking water at the recommended level of 0.7 milligrams per liter is both safe and effective. This is based on more than 75 years of experience and research. All right, so CDC kind of versus the EPA role. The one thing that I like to reiterate regarding CDC's role in water fluoridation is that we do not serve in a regulatory capacity in any way. We are here to provide national guidance and surveillance and to support state and local fluoridation programs so that they are successful and so that water fluoridation is done both safely and effectively. So most of you may be aware of the limits, but just a quick reminder of what EPA and also your state drinking water branches are tracking from a regulatory level. With that, the maximum contaminant level limit of 4.0 milligrams per liter and a secondary maximum contaminant limit of 2 milligrams per liter. The level, as you see on the right, as a health intervention, as recommended by the US Public Health Service, is 0.7 milligrams per liter. So you can see that there is a wide range between these two limits. So CDC, in conjunction with the state programs, help track those systems that are providing fluoridated water at these lower limits. So we are picking up what water systems are doing that the regulatory agencies may not, because you aren't hitting the limits that they are looking for. So you can see, obviously, though, with the gap, this leaves a huge gap in data that is not collected for the 73% of the population on community water systems that receive fluoridated water, and the almost 18,000 community water systems that are receiving fluoridated water. So that's either by adding fluoride that have natural levels or are purchasing from a fluoridated water source. So as I said, this is where CDC and the states come in to collect and track this data. So here's a general list of the Division of Oral Health at CDC's water fluoridation activities. It includes conducting national water fluoridation surveillance, providing and assisting with training. We help develop community water fluoridation resources and are heavily involved in providing technical assistance to states and individual water systems when requested. So as far as surveillance and nationwide coverage, CDC releases a summary of these statistics in the form of the biennial statistics every 2 years. These statistics are based on the fluoridation status of water systems in all 50 states and DC. Here are Missouri statistics as of 2018. I will note that the 2020 data has not yet been released. We typically have about a year of data lag to get our system up to date before releasing the statistics. But based on the 2018 data, you can see Missouri is doing better than the national statistics with 75.6% of state population on water systems receiving fluoridated water versus 73 at the national level, and are also very close to hitting the US target for Healthy People 2030, which is 77.1%. So for those of you that may not be familiar, Healthy People is a set of nationwide health promotion and disease prevention goals set by the US Department of Health and Human Services. This 2030 goal was released in late August of last year. Just some also general notes about the water systems in Missouri. As I already noted, you have over 90 systems that are practicing water fluoridation or adding fluoride to the drinking water, and over 100 natural systems that are receiving optimally fluoridated water from natural sources. So our data systems. So at CDC, we maintain 3 data systems that collect or display water fluoridation data. Our water fluoridation reporting system, or WAFERS that we call it, is the backbone as it collects the data that is eventually displayed to the public in MyWater's fluoride and oral health data. WAFERS is also a data tool for states to use for surveillance and management of their fluoridation programs. But I will note that it is completely voluntary for states to participate in our data collection and WAFERS, except for just some requirements for our funded states. We also use the data in WAFERS for the biennial statistics that I just talked about and the quality awards that I will go into in a couple more slides. The last time, I just want to note that WAFERS had a major overhaul was in 2010 with what we call WAFERS 2.0. So we are excited to begin the process of looking at the next kind of imagining of what the database will look like. This fall, we're going to start an assessment of WAFERS and see what a new, now we're calling WAFERS 3.0, would look like with data modernization and cloud-based capabilities. The reason that I bring this up in this forum is that we know that EPA and the state CIDWIS programs are also going through a similar process at the same time. So the hope is when we come up with this new system, that it can maybe be a little bit more compatible or integrated with some of the state drinking water systems to maybe reduce some of the burden on the state reporting. Obviously, with the ultimate goal would be to increase both the data quality and also the data quantity we are getting by increasing state active participation. So I do want to briefly touch on our public-facing water fluoridation tool. MyWater's Fluoride is how the public can view data that is reported to WAFERS. Participation, as with WAFERS, is voluntary, and currently we have 42 states participating in MyWater's Fluoride, and then 32 states that display some additional state reports that gives a little bit more information from our WAFERS database. As you can see, Missouri is one of the states that currently displays both general water system data and reports. To be able to navigate the system, the public user must know the county that they live in and also the water system name to be able to pull the data. Right, so this is just an example of a landing page for a water system in MyWater's Fluoride. You can see that it lists the county, the PWS ID, the fluoridation status, and then also the population served. There's also messaging that can inform consumers on fluoride exposures, so they can talk with their health providers on whether supplements might be necessary in low fluoride areas, or even if they might be getting too much exposure for fluorosis purposes. This system, as you maybe see, it's maybe a little blurry for you all, receives fluoride from natural water sources, and you can see that it is a little bit on the higher end versus the 0.7 recommendation, but is still below the secondary maximum contaminant level. Right, so our quality awards. The CDC administers, along with our partners at the Association for State and Territorial Dental Directors and the American Dental Association, quality awards for both the state and individual water systems on a yearly basis. The PWS awards, or the Public Water System Awards, reward those systems that add fluoride if they have reported data to the state and to WAFERS for 12 months, and all months have been within the state-specific optimal range. This is really CDC's way of recognizing both the state fluoridation programs and the individual water systems for the great public health benefit that each of the water systems are providing each year. We are actually currently starting to look at some ways to kind of revamp the award program, and I would definitely be happy to hear from any of the water operators familiar with the awards or any other stakeholders on this call for any suggestions for improvements and incentives for the future. We know in some states it is a challenge to get 12 months of data, many times because the drinking water branches don't require reporting on that frequent of a basis. So these awards are not only used to congratulate the water systems for fluoridating successfully for all 12 months, but also for going above and beyond their regulatory duties to provide us data and also provide healthy water by practicing water fluoridation. All right, so we are actually just now approaching the award season for the 2020 awards. So we give out the awards, so it's 2021, so we give out awards for 2020. But I can tell you that we gave out over 1,500 awards in 2020 for the 2019 Quality Awards. This was a little bit less than the year prior to that, but it was expected with kind of operational reporting issues that were anticipated due to COVID-19. Unfortunately, we do expect for some more difficulties this year with reporting, but we already have a list over 1,000 awards and should have even more once verified with all the states. All right, so just to touch on the 2015 recommended fluoride level real quick. So in 2015, the US Public Health Service updated the recommended optimal level in drinking water. It had actually been over 50 years since the recommendation had been reviewed, and there had barely been a lot of scientific breakthroughs in dentistry and dental health, additional scientific studies on fluoride and fluorosis, and even a lot more fluoride exposure since that time, obviously including fluoride toothpaste. Additionally, the previous recommended ranges were based on ambient temperature, as it was thought that if you lived in a warmer climate, you would have more exposure, i.e. you would drink more water because it's hot. However, data and studies indicated that water consumption, in fact, did not vary by ambient temperature as previously thought. So that was not a factor in the updated recommendation. The optimal level was revised to 0.7 milligrams per liter for across the board, across the US. It showed, based on studies that showed that this threshold still provided maximum health benefits while reducing exposure. I do want to reiterate that 0.7 is the recommendation and target that we want every water system to be striving for. We know that hitting 0.7 from an operational standpoint is not always achievable based on various factors. So an operational tolerance range can be set. CDC does have a draft operational tolerance range of 0.6 milligrams per liter to 1.0 milligrams per liter. That has not yet been finalized, but we have been socializing to the states, and a lot of the states have started to adopt. Based on studies, though, I want to point out there is a large drop off in benefits less than 0.7, and it's even steeper when below 0.6 milligrams per liter. So I understand that operating at the lower end of this range is usually what is preferred to save on operational costs, but just want to remind everyone that this should not be the standard operating practice. That 0.7 is really what we're trying to maintain. All right, so kind of moving more into the more technical portion of the presentation. These next few slides, I'm going to go into a bit more detail on the types of approved additives for water fluoridation. The first and most widely used, in fact, at least based on our database, all but one system in Missouri currently uses fluorosilicic acid, or also commonly called FSA. This product is a fairly strong acid with a low pH. However, the product is most widely used, and is essentially usually kind of a plug and play application, as there are no saturation times or mixing as required with the dry feed applications. All right, so there are two dry additives commonly used for water fluoridation. The first is sodium fluoride. This was actually the first product to be used when water fluoridation was starting up over 75 years ago. It is actually produced by neutralizing FSA with caustic soda. This is typically used in saturator equipment and more commonly used by smaller water systems. As you can see, this accounts for only about 7% of the fluoride additive used across the US, and does require water softening for hard water situations, but does have a constant solubility. All right, so the second dry additive is sodium fluorosilicate, and this is the product that the other one system in Missouri is using. So no one's using sodium fluoride. It's produced by neutralizing FSA with sodium carbonate, and this product is used in dry feed applications and is also used in both large and small systems across the US. This product accounts for approximately 13% of the product used in the US. But one important item to remember when using this product is that it is temperature dependent. So solubility can vary and full saturation takes longer than it does with sodium fluoride. All right, so for those of you that are using FSA as your fluoride additive, handling and safety are obviously major components, as I noted that it is a strong acid. Particularly, gauntlet gloves, full face shields, splash-proof goggles, aprons, and being close to safety showers and eye wash stations within reach are all important items for FSA handling and safety. If you're using any other strong acids in your drinking water, or if there are any wastewater folks on the call, this is obviously just all pretty standard safety gear that you would need to wear. With safe storage and handling, however, the risk to the water operator really can be minimized. All right, so although much easier to handle, the dry additives also have their handling and safety considerations. Particularly for these is the impact of dust when opening up bags of the product. So many times the equipment is located in a small confined spaces. So face masks and eye protection are critical to reduce dust exposure. All right, so this is just a quick simplified overview of a typical FSA system. As I noted, this is the most widely used fluoride additive, and this is primarily due to many water systems being familiar with using aqueous-based additive feeds like a sodium hypochlorite. So the process is simple in that bulk deliveries can be stored in storage tanks up to 10,000 gallons and then transferred to a day tank where the feed rate is controlled by a metering pump and then eventually diluted into the water flow. The bulk storage and day tanks are usually preferably polyethylene due to the compatibility with FSA, but there are some fiberglass tanks out there as well. FSA has a freezing point of around 0 degrees Fahrenheit, so most of the FSA systems in Missouri are probably found indoors, or if not, with some thermal installation and heat tracing. Otherwise, this is just a graphic of the general setup for an FSA system, which I noted is kind of very similar to your typical liquid chlorine system. Right, so FSA systems are typically stored in a dedicated room or enclosed area at the treatment facility. Beyond that, the absolute most important storage consideration is to make sure that the tanks are properly vented. Hydrogen fluoride evaporates at around room temperature, so a small quantity, usually about less than 1% of volume, can volatilize if not properly vented. Improper venting, vent pipes with leaks, or open releases allow corrosive hydrogen fluoride to release, so all connections that could possibly release gas should be vented to outside the building. If corrosion is observed, then the installation most likely has a leak, which should be identified and fixed. However, a correctly installed system will not have any evidence of corrosion. So some things to look out for when we're looking at, maybe where there might be some leaks would be observation of glass etching, accumulation of fine sand, and any maybe corroded metals inside the room itself. These are all indicators that there might require operator attention to identify leaks and then correct them. All right, so day tanks. Day tanks prevent FSA overfeed by limiting unintended release of more additive than would be used for one day. This is one of the most important protections for fluoride-additive overfeed due to equipment failure. So if possible, it's preferred to avoid filling day tanks by gravity, and it's typically best to use manual pumping to refill day tanks so that no overfilling occurs. So the picture on the right, you can see that this small water system uses a smaller tank next to the bulk tank and also has 2 valves on the fill line, requiring both valves to be physically open to transfer contents. However, you see it is, this is running by gravity. We will note that we do think it's better to use a pump to transfer the contents. And also to have the day tank higher than the bulk tank so that in the event of overfilling, you won't have any issues. Also, a reminder again that all tanks and pipe connections need to be vented. Since the amount of off-gassing is small, probably in this case, in this picture, because it's a smaller setup, a small hose would usually suffice for venting. However, many times vent lines will be larger than a tube hose, as many building codes require vent lines to be the same size and diameter as the actual fill line coming in. All right, so I won't spend too much time on the sodium fluoride or saturator systems, as you currently don't have any systems using this product. However, I'll go over some basics just in case there are any water systems that might consider switching over to this type of system. Sodium fluoride is a crystalline salt and commonly delivered and stored in 50 to 100 pound bags. As far as storage, the room housing the product should be properly ventilated to avoid dusting or blowing of the fine grained product. We also recommend that it should be a dedicated dry additive storage room if possible. The sack should be stored on an elevated platform to protect from moisture. And we do have a recommendation that they should not be stacked more than 6 high. And typically we want you to have a limit of 6 months supply just to make sure that the supply is staying fresh, as you'd say, just to not have any moisture issues. In the last few years, I will note supply of dry additives have been a bit more challenging as most of the products are manufactured outside of the US. Therefore, keeping up with the 6 month supply and also making sure that the dry products are reordered well ahead of time are becoming more and more important. I will say with the dry products as well right now, we are seeing in some spots across the country, just because of the supply chain issues that are happening across the board with COVID, we are seeing some shortages in supply. So that's even more important to make sure that you keep in contact with your suppliers and make sure you are reordering well ahead of time. I will note that sodium fluoride will dissolve quickly. It's normally within 5 minutes to a full saturation solution. Since it is not temperature dependent, sodium fluoride is typically used in a saturator to create a reliable solution for feeding to the water flow. Since the saturated solution is a known concentration, managing the feed rate is usually pretty simple. Because of the ease of managing the feed rates, this usually makes the use of saturators ideal for water systems, especially if you want to use a dry product. Here's just a quick example of what a saturator looks like. The saturator itself looks a little bit like a water softener tank, but works a little bit differently. The salt product is poured into the saturator and settles to the bottom through the saturated solution that resides above the bed. Makeup water is added at the bottom through a distributor and is saturated with sodium fluoride as it rises up through the bed. One operational consideration with a saturator is that over time, the sodium fluoride dissolution will result in an accumulation of some insoluble fluoride product and does require clean out of the residual bed contents and then the replenishment of fresh media. But for small systems, this usually is as infrequent as once a year. This is just a quick diagram of, kind of what the saturator looks like. And then also included in the slides, we have a fluoride saturator troubleshooting guide. This was actually taken directly from our online training, which I will talk about at the end of the presentation. But if you would like or need a copy outside of this presentation, please feel free to contact me as well. All right, so moving on to sodium fluorosilicate. Sodium fluorosilicate storage and delivery are similar to sodium fluoride. It is most commonly delivered in bags, but it also is available as a supersat quantity, which is roughly about the same amount as a pallet of bags. Sodium fluorosilicate must be dispensed using a dry feeder as it meters the product at a predetermined rate. The feeder dispenses the product into a mixing tank. Since the resulting solution is unsaturated, the actual fluoride level in the unsaturated solution is unknown. So the chemical feeder is what's controlling the dosage. So the unsaturated solution will deliver the correct level of fluoride into the system. The unsaturated solution is conveyed from the mix tank to the water flow feed point, usually using an eductor or a feed pump. All right, so just some quick notes on the dry feeders. As I noted, the dry feeder delivers a precise measured amount of sodium fluorosilicate additive to the mixing tank, creating an unsaturated fluoride solution. There are two types of dry feeders. A volumetric feeder delivers a defined volume of additive using a rotating screw or helix. A volumetric feeder is typically less expensive, but does require periodic recalibration to maintain consistent product delivery. The other type is a gravimetric feeder, which incorporates an integrated scale to deliver a measured mass of fluoride additive. Gravimetric feeders are usually more reliable, but tend to be a little bit more expensive. I will note that sodium fluorosilicate requires a minimum of 5 minutes to fully dissolve into an unsaturated solution. So therefore, the solution mixing tank should be sized for a 5 to 10 minute detention time to ensure sufficient dissolution of the additive. I'll also note that the time needed to achieve full dissolution can rise, probably about 10 to 15 minutes when treating hard water or water that is colder than 60 degrees Fahrenheit. One plus for the use of a dry feeder is that while dry feed equipment is more expensive than a fluoride saturator when we're talking about the dry products, you can also use sodium fluoride additive in a dry feeder application. That is not the case for a saturator situation. You can't use sodium fluorosilicate, but with the dry feeder, you have that flexibility of using either of the dry products. All right, also just another troubleshooting guide that came from our online training. All right, so I wanted to touch quickly on the feed location for the fluoride. This obviously will depend on the configuration of your treatment facility. I understand that this can vary widely, as there may be systems with large treatment facilities or systems that are really small well systems that are basically only using some chemical addition to treat the water. However, for all systems, this should typically be after any treatment processes and at a location, obviously, where all the water will pass. So for a large system, this would typically be right before you go into a clear well, or for a smaller well system, probably after the chlorine addition and right before the water would hit the distribution system. When using other chemical treatment chemicals, I want to note, though, there are a couple items to consider when it comes to fluoride addition. Chemical solutions containing calcium, including lime, do have the potential to form a calcium fluoride scale. Additionally, facilities that are using alum can experience some fluoride loss if added after the fluoride. So therefore, the fluoride addition point should be after the addition of these chemicals. Adding fluoride too early in a lime soda ash treatment process can also result in loss of fluoride. And then additionally, if your system is using colorimetric testing methods, fluoride should be added before any phosphate addition, as it can interfere with those testing methods. All right, so just some general overfeed considerations. Possible overfeeds are rare, but can happen, as with all chemicals added for water treatment. Continuous annualizers, particularly for FSA systems, and level alarms obviously are key. If any of you are familiar with the Sandy City, Utah overfeed, this was actually caused kind of by the perfect storm of various factors, including faulty alarms and also faulty automatic shutoff valves. This was also a well system that had not been in use for almost 3 years, but was still functional. So it's also important to make sure, if any of your water systems are in this situation, that you have unused well applications, that the unused product is either drained or taken completely offline until long-term use is planned. So if you are planning on having some maintenance or some other work done at the plant and are concerned, it is definitely better to take the fluoride system completely offline. Because remember, a small disturbance in low fluoride levels, just for a few days, will not affect the health benefits. So it's much better to maybe have a small disturbance than it would be to have an overfeed situation. Just generally speaking, though, this list also includes some other general considerations to look at to help ensure that overfeeds don't occur. Okay, so I also just want to quickly touch on the testing methods for fluoride in your finished water. The two most common methods are the colorimetric, and the other is using an ion-specific electrode. Generally speaking, the ion-specific electrode method is the more accurate and precise methodology. It measures the ionic activity, much like a pH probe. The colorimetric method, however, is the most commonly used, but just note that it typically isn't as accurate as the ion-specific electrode. The colorimetric method relies on measurement of light absorption by water and ions. This results in the potential for many interfering substances, differences in water color, turbidity, oxidants that affect color. A lot of these can have an effect on this method. So standard methods does specify the use of acid refluxing of the sample to reduce these potential interfering substances. But we do know that this method is typically not done with the colorimetric method. So if you are using a colorimeter, I would just suggest that you either keep track, do some independent testing every once in a while, just to make sure that the testing is remaining accurate with your meter and with everything that's going on in your treatment system. All right, so here's just a quick list of additional resources regarding water fluoridation. These are kind of more the technical resources that we would recommend for water operators, engineers, et cetera. There are a few of these. Unfortunately, the few items from AWWA do typically cost some money. However, if you do want to splurge, this M4 manual on water fluoridation is definitely a great resource. All right, so finally, our online fluoridation training. So CDC launched our first web-based fluoridation training in April of 2019. It is a free course that is administered through our CDC Train platform. Just to give you all some brief history, CDC used to put on a multi-day in-person training session that twice a year. There's one in Tennessee and the other in Sacramento, California. These classes, though, had a cap of about 40 people. and we're geared towards training state oral health employees and fluoridation coordinators. So CDC realized that there was obviously a huge population that we were missing with these trainings, including water operators, dental hygienists, and many other stakeholders in both the drinking water and oral health communities. So to meet a larger audience, CDC developed and launched Fluoridation Learning Online, otherwise known as FLOW sometimes, through our CDC Train platform. As I mentioned, it is free and it is open to the public. So far, we've had over 1,000 people register for the course to date, which we think is pretty good because that has been done without any really major marketing to water treatment operators, as we have worked with states to try to attain water operators CEUs. So far, you can see there are 8 states, as shown on the slide, that have been able to get CEUs. You will see that Missouri is one of those states that's in bold. Gwen can probably confirm in her presentation, but I know that either you guys have received permission for CEUs or are very close. So this is just an overview of the modules in Fluoridation Learning Online. Modules 3 and 4 are really the more technical water system modules that include information on dosage, design considerations, additive products, safety, etc. But even from a drinking water perspective, we do urge water operators to also take the first 2 modules so that they have a full understanding of the benefits of water fluoridation, and also could maybe benefit from some of the communication aspects in module 2. And also in module 2, it's kind of good to just know how these state fluoridation programs are working. We have that outlined in that module as well. All right, and the last thing that I will note is we also have what's called Fluoridation Resources Online. It went live last fall and is also found on the CDC Train platform. It's a free, non-credit, untimed version of the CDC's Fluoridation Learning Online, and is actually designed to kind of be the lasting resources for water operators, fluoridation program managers, or anyone else who want to have a resource to be able to come back to after they maybe have taken the Fluoridation Learning Online training, because unfortunately, there are ways for you to save favorites as you're going through the training. Once you're done, it pretty much resets. So the Fluoridation Resources Online is really meant to be kind of the lasting resources for those who really want to use this for day-to-day applications. And with that, I just want to thank you all for inviting me to be on this webinar, and look forward to any Q&A that you have, but also please feel free to reach out to me if you have any questions.
Thank you, Tracy, for your presentation. We had a couple of questions come through the chat, but we're going to hold all questions until after Gwen's presentation.
Okay.
So our second presenter this afternoon is Gwen Solentrup. And Gwen is the Community Water Fluoridation and Sealants Coordinator with the Office of Dental Health with Missouri Department of Health and Senior Services. So Gwen, if you are ready, you can go ahead and turn your presentation on.
Thank you, Ashley, and thank you, Tracy. That was a great presentation, and thank you, Gary, for co-hosting this with us and with the Office of Dental Health. So my name is Gwen Solentrup, and some of you may know me from visiting water out plants, or just from general conversation. So I'm going to talk today a little bit about Missouri's Community Water Fluoridation Program. And some of what I have is going to be a duplicate of what Tracy already presented. So I won't spend a lot of time on those slides, but we'll get started. So just to let you know, this presentation is part of a larger, more comprehensive presentation from the CDC on Community Water Fluoridation Program. And I have no real or perceived vested interest in the presentation, nor do I have any relationship with pharmaceutical companies, biomedical devices, and or other pertinent therapeutic areas. So dental professionals are not the only people who play important roles in preventing tooth decay. Water operators also play a crucial role in the fight. They provide clean drinking water to residents, and in the public water systems where they add fluoride, they provide an important public health initiative that helps prevent cavities. So community water fluoridation began in Grand Rapids, Michigan. That was the first city to come online in the United States, and that was in 1945. As of 2018, nearly 73% of the United States served by public water systems have access to fluoridated water. So in Missouri, the first city to come online was in St. Louis, and that was in 1954, and they have continued fluoridation since that time. In 2020, community water fluoridation was celebrated the 75th anniversary in the United States. So we now have 75 years of information and data compiled, giving us information about water fluoridation. So fluoridation is the precise adjustment of fluoride in the drinking water to a level optimal for the reduction of tooth decay. So you take the natural fluoride amount that's in the water already, which in Missouri is about 0.2 to 0.23 milligrams per liter, and you will add the fluoride additive until you reach 0.7 parts per million or milligrams per liter. So that's the target optimal rate goal that we want you to be at. There is a recommended range of 0.6 milligrams per liter to 1.0 milligrams per liter. So anywhere within that range, they're going to get benefits that help stop tooth decay, but 0.7 is the target area. So fluoride is a natural mineral, fluorine, and it occurs in all water as a result of the geological composition of the soils and bedrock. The amount of fluoride in water depends on the types of water. So Tracy covered part of this, but surface water, rivers and lakes typically have lower concentrations of fluoride in the water at 0.2 milligrams per liter or parts per million or less. Groundwater, which are going to be your deep wells, have higher concentrations of fluoride in the water, and it can range from 0.1 to 10.0 milligrams per liter. Ocean water is probably the most constant fluoride concentration on Earth, and that's around 1.4 milligrams per liter. So Missouri does have pockets of areas that have naturally occurring fluoride levels, and those range anywhere from about 0.6 milligrams all the way up to about 4.0 milligrams per liter. Of course, anyone that's over that 2.0, DNR works with them to help them get that brought back down. But we do have pockets here that already have the optimal level and do not add fluoride to their water system. There have been over 3,000 scientific studies that have proven the safety and effectiveness of water fluoridation. In 2020, the 8 U.S. Public Health Service chief dental officers from 1981 to 2018 all signed a statement to reaffirm their support and commitment to community water fluoridation. So these are some issues that can result from tooth decay, caries, cavities, however you would like to refer to it. And all of these can affect everyone, no matter age, no matter socioeconomic status, race, gender. So they can affect everyone equally. So tooth decay is the #1 chronic disease of childhood in America, even though it's almost always preventable. There are health disparities in dental care in the United States. Low-income children and children of color are more likely to have untreated decay due to lack of access to dental care providers or to funding to cover the dental care. These high-risk groups are public health's primary target, and tooth pain can affect a person's ability to eat, sleep, speak, socialize, and children with poor oral health are more likely to miss school and earn lower grades. The U.S. Surgeon General's report in 2000 indicated that children miss more than 51 million hours of school annually across the United States due to oral health issues. And whenever you have kids missing school, of course, you're going to have parents that are also missing work. And that, again, creates a larger disparity with socioeconomic status. So approximately 90%, 96% of adults age 65 or older have a cavity, and 1 in 5 have untreated tooth decay or have lost all of their teeth. So these are risk factors for tooth decay. Poor diet, poor oral hygiene, dry mouth that could be caused by medications or health issues, high bacteria levels, which can adhere to the enamel of the tooth, can all cause cavities to form in your mouth. So let's talk for just a second about the cost of a cavity. You can look at this diagram and kind of see what the lifetime estimated cost is about $6,160. That's potential for someone who has a cavity, starting with the filling, getting replacement filling, moving on to a root canal and crown, then ultimately extraction. And if they want to have a tooth in that spot, an implant or potentially a bridge or dentures that could have to go in. So even with insurance, the lifetime cost of a cavity can be thousands of dollars. And there's easy steps that everyone can follow to help reduce it. Visit the dentist twice a year for cleanings and exams, brush twice a day and floss regularly, avoid all forms of tobacco. And here's the one that I think is important: drink fluoridated water. So let's talk a little bit about fluoridation. So at the start of the 20th century, life expectancy in the US was 45 years old. Extensive dental caries was common, and that's tooth decay. And in the absence of effective preventive measures, often resulted in tooth extractions. These extractions were routine in young children, and by school age, a child had 3 to 4 new cavities each year. The combined effect of tooth decay or dental caries and periodontal diseases made indentulism or toothlessness a normal expectation for mature adults. This led to dentures being presented to brides and high school graduates as gifts. Additionally, because of toothlessness expectation in adults, the military began having all recruits go through an oral exam before signing them up for the military. This led to many World War I and World War II recruits being rejected due to poor oral health. Of the World War II recruits, 10% were rejected for failing to meet the minimum standard of 6 opposing teeth and were listed as having an established dental defect, and 40% were rejected for immediate treatment to relieve pain. The lack of 6 opposing teeth was a leading physical reason for rejection of military recruits at the beginning of World War II. So a lot of people used to think diabetes and other lifelong diseases were actually the leading reason, and it's actually poor oral health. So due to so many issues with dental health and other medical issues during World War II, the military created the individual medical readiness test, and each new recruit had to pass that before signing up and being able to be deployed. This test is comprised of 6 components, and the one I'm going to talk about is dental readiness. So the Department of Defense defines dental readiness as fully medically ready, current in all categories, including dental class 1 or 2. And the DoD requirement for military personnel is 95% or higher military readiness. So since there's different levels of medical readiness, service members who are dental patients are grouped into one of 4 categories, determined by the assumed likelihood of experiencing an emergent condition within a 12-month period. So those classes are class 1, which is a current dental examination has been completed and no additional dental treatment is needed for 12 months. Class 2, a current dental examination has been completed, but the member requires non-urgent dental treatment or reevaluation. Class 3 is a current dental examination has been completed, but the member requires urgent or emergent dental treatment. And there are 13 different conditions that can fall into that category. Just a handful of them are dental caries or cavities, tooth fractures, defective restorations, and it's things that cannot be maintained by the patient, or chronic oral health infections that are going to require emergency treatment at some point within the next 12 months. Class 4 is a member is overdue for an annual dental exam, or their dental status is unknown, which means they've never been to the dentist. There's no record on file showing exactly what their oral health condition is. And any member of Class 4 is automatically not considered for deployment. So in 2008, 52% of new recruits in the US Armed Forces were categorized as having oral health problems, needing urgent attention, and it delayed their overseas deployment. In 2011, a senior official with the DoD reaffirmed the policy of fluoridating water supplies for all military bases, pointing out fluoridation will directly reduce the risk for dental decay and improve military readiness. In 2016, the DoD mandated that any DoD installations in the US or its territories that own or operate a potable water treatment facility serving 3,300 persons or more must provide optimally fluoridated water. And the reason listed was dental decay was identified as the most significant reason for military personnel to be classified as non-deployable. And in order to help slow and reduce the dental decay, they recognize that optimizing fluoridated water is the best way to do that. So even now, 60 years after World War II, one of the main reasons recruits are non-deployable is tooth decay. So it still continues. And currently both Fort Leonard Wood and Whiteman Air Force Base receive optimally fluoridated water. So in 1901, Frederick McKay established a dental practice in Colorado Springs, Colorado, and he began treating patients there. He noticed they had a brown stain that they referred to as the Colorado brown stain, and that it was difficult to polish off the teeth. This led Dr. McKay to deduct the stain must have occurred during the period of enamel formation and was most likely caused by an environmental agent. Only lifelong residents had that stain, so it meant that anyone new to the area was not affected. The model enamel was referred to as dental fluorosis. And in 1920s, Dr. McKay discovered the environmental factor causing the brown staining was coming from the drinking water. Their drinking water was supplied by deep wells that had fluoride levels of 4 milligrams per liter or higher. So in 1928, he discovered the fluoride levels that they had also gave them a benefit to help fight against cavities. So this is where water fluoridation kind of got its birth. So in sequential cross-sectional surveys in the early communities over a 13 to 15 year period, caries or cavities was reduced 50 to 70% among children. Some of the trials included a periodic physical exam of the participating children, but the most important thing to take away is that there were no adverse health effects that were detected then or now by the utilization of optimally fluoridated water. So why fluoridation? Well, fluoridated communities have 20 to 40% less tooth decay. Water fluoridation helps prevent cavities an additional 25% beyond the current fluoridated products, and that includes toothpaste, mouthwash, fluoride varnish treatments that you receive at the dentist. So it gives an additional protection. It's the single most effective intervention, and it saves money. In Missouri, on average, it saves $32 in dental care per person per year. So the population in Missouri that are on fluoridated water is about 3.8 million people. So that means on average, Missourians save about $121 million a year. And it also benefits all consumers across socioeconomic status, race, gender, age. It doesn't have a discrimination factor. As long as you're drinking the water, you're getting the benefit of the water. And those benefits can last a lifetime. So fluoride has two benefits, topical and systemic. At the systemic level, it is incorporated into the enamel of the teeth as they are forming, and it combines with phosphate and calcium to create a stronger surface that's more resistant to tooth decay. To decay causing acids. Earliest research hypothesized that fluoride affects enamel and inhibits cavities only when incorporated into developing dental enamel or before the tooth erupts. So as those babies and children are drinking and using the fluoridated water, they're getting a systemic benefit. And the hypothesis is that it does work. But the predominant effect is going to be topical. So that means after the teeth have erupted or they're already formed in the mouth. Those effects depend on fluoride being in the right amount in the right place at the right time. So that means having optimally fluoridated water at 0.7 milligrams per liter, drinking it consistently or using it to cook with. And it works best when it's in when small amounts are maintained constantly in the mouth. So adults can also benefit from it. It doesn't just help children. And fluoride inhibits demineralization and enhances remineralization of the surface enamel. So adults now are keeping their teeth longer, making them more vulnerable to decay. Where we used to go to the dentist, and the first thought that came to mind was probably pull a tooth that had a cavity. Now there's treatments that are used, and because of that, as people are aging, they're keeping their teeth longer. So root surfaces get exposed by receding gums. A lot of older adults experience dry mouth due to medications and health issues. And due to problems with dexterity and being unable to brush thoroughly, it causes them to be more susceptible to decay. So as that fluoride is topically on their teeth with water fluoridation and it's remineralizing their enamel, it's helping protect their exposed roots and make their teeth more not as vulnerable to decay. So a summary of all studies since 1980 show adults age 45 and older indicates that older adults may experience similar or higher levels of new decay as school children. So fluoridated communities don't just benefit the people that live there. And that's called the halo effect or diffusion effect. And it's the effect of water fluoridation on residents of localities where drinking water is not fluoridated. So those residents from surrounding areas of a fluoridated water system come to your town, they visit, they're drinking drinks there that have fluoridated water, or they're getting vegetables and fruits and things like that from areas where there's fluoridated water. And so because of their exposure to that, there's a positive benefit that reaches beyond just the general community and allows them to receive some benefits from having that fluoridated water in whatever food or beverage they're ingesting. So the more communities that have fluoridated water makes for a stronger halo effect. And pretty soon it starts just, you can just see a circle coming out around that area. So we're going to talk for a little bit about water fluoridation and Department of Health and Senior Services. So as I said earlier, water operators have their primary job, of course, is to keep the drinking water clean and that they're offering to the public, but they also are able to fluoridate the water, offering a great public health benefit. So in order for them to achieve the goal of clean drinking water, there's two supporting government bodies that are able to assist with questions and educate about water fluoridation here in Missouri. So one of those being the Office of Dental Health, which is housed by the Department of Health and Senior Services. And we serve as the government body supporting community water fluoridation for the public health benefit it achieves for Missourians. The second governing body is the Department of Natural Resources, and they are responsible for the regulatory side of water fluoridation. So they're the ones that are going to want you to be testing, making sure your equipment is set up correctly, and answer all of those questions related to specifics about how the system should be working. So the Office of Dental Health is able to assist water systems and districts, decision-making bodies of local municipalities, and the general public. We work directly with water systems or districts to help answer questions about aging equipment, broken equipment, cost of additive, operator safety, and how to handle the fluoride additive safely. We do this by visiting and touring local water systems to ensure the age of your equipment, how it's working, how it's set up. Are you guys using a day tank? Is it a direct feed into the system? We have discussions with water operators about how their fluoridation system currently works and the benefits that it's providing to their consumers. And then we will also talk about additive costs and how we can help reduce the cost of testing supplies, equipment, things like that through funding. And one of our primary goals is also to increase operator safety across the state. So that way we know that you guys are working with the most up-to-date materials and things like that to handle the additive. We also offer education about the benefits of water fluoridation. We have handouts, infographics, data, and other materials available to help provide information about water fluoridation in your area and the state in general. And we visit with local groups, decision-making bodies, schools to promote and educate about water fluoridation. So in Missouri, as in all other states, there are statutes. Missouri has two statutes that are regarding water fluoridation in particular. We do not have a mandate that states that every water system has to fluoridate. That's a question that I receive a lot from operators. And no, Missouri does not have that. However, we do have two statutes that we refer to regarding fluoridation in general. So 640.135 refers to DNR remaining neutral on the topic of water fluoridation and advising in a regulatory scope. So they cannot tell you that you should fluoridate your water. They cannot tell you that you cannot fluoridate your water. They're there to provide education on if you're going to do it, make sure that you're meeting engineering codes, make sure that you are meeting regulatory codes and testing and doing those types of things. So RSMO statute 640.136. This is the statute involving notification if you're going to modify the fluoride either being added or removed from your water system. So Missouri is one of only 5 states that has a law like this. And this law basically states that you have to give Department of Health and Senior Services, Department of Natural Resources, and your consumers 90 days of notification before you make any modification, that's addition or subtraction of fluoride to your water supply. There is a form, which I will show you on the next slide, that has to be filled out and sent into DNR. And then that form is also forwarded to the Office of Dental Health. And you have to notify your customers. And you can do that via radio, television, newspaper, regular mail, electronic means, or a combination of any of those. Most of the time, water systems put it on their water bill for the 90-day period, stating that they're going to consider adding water fluoridation to the water supply, or they're going to remove water fluoridation from the water supply. So if we find out for some reason that you've stopped fluoridation, then usually DNR will work with you to try to figure out what you need to be doing, and they will ask you to start fluoridating your water system again until that 90-day notification period is up. So at the end of that 90-day notification period, what happens is a decision-making body will make a vote to determine if they want to add or want to remove the fluoridation from the water supply. Here is the form. I know it's a little bit small, but this is the form and this is the link to get to that form. And this is the form that has to be turned in 90 days prior to any vote, or even before the process begins. And this again goes to DNR and then on to the Office of Dental Health. So public drinking water does have regulations, and Tracy touched on this a little bit. So the Safe Drinking Water Act was passed in Congress in 1974. with amendments in 1984 and 1996. So this act protects our drinking water and authorizes the EPA to set standards and regulations for many different contaminants in the public water system, including disease-causing germs and chemicals, and to monitor states, local authorities, and water suppliers. The EPA sets treatment requirements for over 90 different contaminants, and they don't specifically regulate levels of direct additives, which are additives added to the water in the course of treatment. It does specify that the addition of chemicals as part of the treatment process should not be more than the maximum contaminant level concentration for regular substances. So the national primary drinking water regulations are standards and treatment techniques that public water systems have to follow, and they're in place to protect the public health by limiting contaminant levels in drinking water. And that includes microorganisms, disinfectants, disinfection byproducts, inorganic and organic chemicals, and radionuclides. And then there's also a secondary drinking water regulation that are guidelines to public water systems to help them manage their drinking water systems for issues not related to health, such as taste, color, smell. And they're not required to follow those quality standards, but they're strongly recommended. So the Safe Drinking Water Act includes a process the EPA must follow to name unregulated contaminants that may require regulation in the future. And these are contaminants that are known or anticipated to incur in public water systems and are not currently subject to EPA drinking water regulations. Since these contaminants may require regulation in the future, the EPA publishes a list called the Contaminant Candidate List every 5 years and decides whether to regulate on at least 5 or more of those contaminants every 5 years. So they will consider health effects and occurrence of information for unregulated contaminants as they make the list. The Safe Drinking Water Act further specifies the EPA must place on those lists those contaminants that present the greatest public health concern related to exposure from drinking water. So I know in the comments there was a mention of bottled water. Bottled water is not regulated by the Safe Drinking Water Act or the EPA. It's actually monitored by the Food and Drug Administration. They have standards that must be met before bottled water may be sold in the US. And that includes standards for physical, chemical, microbial, or radiological contaminants. When the EPA sets new standards for contaminants in tap water, the FDA has to establish new guidelines and new standards for the same contaminant in bottled water. So that way, or find that it's not applicable to bottled water because maybe it's not in the area where they're at. So bottlers must include the name of the product and type of water, the name and address of the manufacturer, packer, or distributor, and the net content of their labels. New bottled water sources must be approved by state or local jurisdiction, and they must test their finished bottled water and their sources weekly for microbiological contaminants and at least once per year for physical, chemical, and radiological contaminants. And then they also have to adhere to the FDA's good manufacturing practices. So many bottled water companies do not have fluoride in the water. So if they do, they have further things that they have to do for that. And they will usually include that on the label. So you can actually look at the label and see if there's fluoride in the bottled water, but most bottled water suppliers do not have fluoride in it, at least at the optimal range. So every public water system or community water supplier must provide an annual report, sometimes called the Consumer Confidence Report. And this report provides information on local drinking water quality, including the water sources, contaminants found in the water, and how consumers can help protect their drinking water. So those are reports that are able to be accessed by the public, and you can definitely go out. Many water systems have them on their website, or you can also go out to DNR's website and access those. So in 1979, the EPA executed a memorandum of understanding with the US Food and Drug Administration, which establishes and clarifies areas of authority in controlling additives in drinking water. So based on this, based on the MOU, the FDA has regulatory oversight for food additives while the EPA has regulatory oversight of direct additives in public drinking water supplies. So the FDA monitors and regulates the intentional addition of fluoride to the bottled water and requires labeling identifying the additive was used. And in 2006, the FDA announced that bottled water with fluoride levels in the optimal range, 0.6 to 1.0 milligrams per liter, could be labeled with the following statement: drinking fluoridated water may reduce the risk of tooth decay. Additionally, the FDA monitors fluoride additives in the over-counter products such as toothpaste, mouthwash, and prescription items like pediatric fluoride tablets or professional strength gels and foams. So today we have a lot of people that drink fluoridated water. I apologize, that drink bottled water for a lot of different reasons. Maybe the taste or the quality of their water supply, they don't think it's up to par. Convenience, it's easy to grab a bottle of water that's already closed in the fridge and cold rather than buying a reusable water bottle and filling it up. But drinking, it's also not just for those reasons. There's a lot of places in the world where there's not clean water supplies. So when they come to the US, it's kind of a cultural preference or ingrained in them that you shouldn't drink the local water and that you need to be drinking bottled water. So making sure in the US that we explain to people that we have safe drinking water supplies is something that we need to be doing, and as well as indicating fluoride additives are safe. So, okay. So fluoridated public water systems adjust the fluoride in the water supply to the recommended optimal level of 0.7 milligrams per liter. But due to the rare occasions where fluoride is naturally present in the water at much higher levels, the EPA established a maximum contaminant level for fluoride of 4.0 milligrams per liter or higher. So if the level of fluoride in the water supply exceeds that level of 4.0, the public water system must notify persons served as soon as practical, but no later than 30 days after the system learns of the violation. The public health goal or maximum contaminant level goal is set to give the public the most health benefits over their lifetime without risk of health-related issues developing. The EPA sets the maximum contaminant level as close to the public health goal as possible. It's not enforceable, and it's based solely on possible health risk and exposure over a lifetime. There's also a secondary maximum contaminant level of 2.0 milligrams per liter. And the secondary level is not enforceable, but if it is exceeded, the EPA does require the public water system to notify persons served and as soon as practical, or 12 months, no later than 12 months from the day that it occurred. So fluoride falls under a list of inorganic contaminants in the EPA CCL. So this means the sample should be collected at the entrance to the distribution system. And also depending on the type of water source, there could be additional testing that's needed. Groundwater sources must be tested once every 3 years, and surface water sources must be tested annually. According to the EPA, fluoridated systems should conduct daily sample testing at entry points and record them. And additionally, the EPA recommends representative point testing monthly with results being recorded. In Missouri, the water operators in public water systems, we have our own testing regulations that need to be followed. And it is monitored by Department of Natural Resources and falls under 10 CSR 60.4.030, 4.070, and 4.080. And I will show you a slide in just 1 second that shows a summary table of 4.080. So if the water system adds fluoride, they must do a daily and quarterly test to check fluoride levels in the water supply. The daily test must be completed at the entry to the distribution system, and the quarterly test must be completed at a representative point in the distribution system. All tests should be recorded and results maintained. The quarterly sample that is collected is sent to DNR for testing at their lab to ensure quality control checks and that fluoride levels are within the recommended range and not exceeding the secondary maximum contaminant level or the maximum contaminant level. So for the best public health benefit, the optimal level or range should be used when a system fluoridates their water supply. So the Office of Dental Health reviews the data provided by Department of Natural Resources to ensure the optimal level or range is being used for systems that are currently fluoridating. If you're outside of that range, the Office of Dental Health will reach out to the water system to ensure equipment is working properly and to answer any questions or concerns the water system decision-making body or local community members might have about water fluoridation. We have been tasked by the CDC with reporting all data for water systems that currently fluoridate their water supply and also to report all natural fluoride levels for every water system in the state. So we take that data that we've gathered and we report it in wafers, which is the water fluoridation reporting system for the CDC. And then they will compile that data every year for us. And then they have the data releases and they use those reports to tell which systems are fluoridated and not fluoridated through My Water's fluoride. And Tracy touched on this a little bit already, so I'm not going to spend a lot of time on this beyond the fact to say that if for some reason you guys are not reporting data, please reach out to us. We'll be happy to take that data from you. And also to let you know that we did do 2 50-year fluoridation awards this year for Poplar Bluff, and the other one was for Charleston, Missouri. And we had a reaffirmation award, which means that a community attempted to remove fluoridation from their water supply, and that was actually averted, and they reaffirmed their commitment to community water fluoridation and recognizing it as a public health benefit, and that was in Park Hills, Missouri. So Tracy also touched a little bit on this. So as a water operator, safety should be one of the most important things for you. And when you work with certain materials, personal protective equipment or PPE is necessary to ensure your safety. Since most of our systems use FSA, we require the neoprene gloves, face shields, safety goggles, and apron. And you should also have a containment system around the fluoride tank or tote or carboy, however you would like to refer to that, and a spill kit in case of a spill, along with a safety shower and eye wash station that's easily accessible by the water operators. So if for some reason you guys don't have one of these things, please reach out to us. We'll be happy to talk to you about that. We have a lot more pages. So public health issues are prevalent in today's landscape for many reasons. Currently, we are faced with a pandemic that has brought public health issues and health disparities to the forefront of conversations. People are looking for solutions to improve their health and finding many populations that are unable to obtain the services and tools necessary to achieve better overall health. And those have been addressed in the Healthy People 2010, 2020, and 2030.
Hey, Gwen, I want to, I step in here real quick. Yeah, well, I don't necessarily want to stop you, but I am, in out of respect for people's time, I wanted to let you know that attendees, you should already have the post-session survey in your email. I think it is going out now, or should have already arrived. And also the code for that survey, I've posted it in the chat. It is effective, is the word, EFFECTIVE. So you have that, so you can complete that. But Gwen, I think if you want to continue with your session, there's nothing wrong with that. And people who can stay on longer will do that. And those that need to get off will. Okay,
I will try, just so I watch people's time, I will try to go as quickly as I can, but still cover all the areas. So some of the issues in oral health include an uneven decline or disparity in tooth decay across the general population. 80% of decay is found in 25% of the children aged 5 to 17 years old. Approximately 1 in 4 children, or 25% of the children aged 3 to 5 and 6 to 9 years living in poverty, have untreated tooth decay. And populations with increased risk include low socioeconomic status, low level of parental education, and little, if any, access to dental care. And all of these are common health issues, oral health issues in Missouri. And one way that we can help fight them equally is through community water fluoridation. So community water fluoridation has been endorsed by over 100 key scientific and professional organizations, and those are just a few of those organizations. And the reason why is because there are benefits to everyone equally. So it's a recognized public health initiative. The CDC named water fluoridation as one of the 10 great public health achievements of the 20th century. And our US Surgeon General, Dr. Murthy, recently stated that water fluoridation is the best method for delivering fluoride to all community members, regardless of age, education, income level, or access to routine dental care. Fluoride's effectiveness in preventing tooth decay extends throughout one's life, resulting in fewer and less severe cavities. In fact, each generation born over the past 70 years has enjoyed better dental health than the one before it. That's the very essence of the American promise. So new oral health initiatives have been developed and are included in the Healthy People 2030. And we tried at the Office of Dental Health, try to align our plans and projects that we do with those initiatives. So as we spoke about Healthy People 2030, so the target goal for community water fluoridation is 77.1%. As of 2016, Missouri was 27th in the nation, and currently we only have about 71.79% of our population that is served by fluoridated water. And as I said before, that's about 3.8 million people. We have about 1,500 public water systems, and only about 24.4%, or 24.39% of those systems either add fluoride to the optimum level or have naturally occurring fluoride already at that optimal level. And that's about 379 systems out of that 1,500. So there are alternatives available to community water fluoridation. In the United States, community water fluoridation is the vehicle of choice, and it is actually the most common vehicle throughout the world of giving optimally fluoridated water, fluoridation supplies. And that's about 400 million people that have access to fluoridated water supplies. The second most common delivery method is fluoridated salt. That began in the 1950s and was first introduced in Switzerland in 1956. And it is currently available in Europe and North and South Americas. Germany and Switzerland have attained coverage exceeding 2/3 of their population, while other countries have met with less success. But early studies conducted by the Pan American Health Organization, which is a regional division of the World Health Organization, showed fluoridated salt might produce a reduction in tooth decay similar to that of community water fluoridation. The third vehicle delivery for fluoridation was fluoridated milk. And we have several countries that are currently doing that: China, Israel, Japan, Russia, Brazil, and the UK. And studies have shown a decrease in tooth decay through the use of fluoridated milk. And it was estimated in 2013 that approximately 1 million children worldwide are drinking fluoridated milk. Dietary fluoride supplements are another way to deliver fluoridation, but those are usually only recommended and prescribed by your doctor or dentist. So there has been a breakthrough in the technology development for community water fluoridation. The new wave fluoridation technology was developed with funding from the CDC to help support rural public health and increase access to water fluoridation. The feeder system itself is NSF, ANSI, and CAN Standard 61 approved, and NSF ANSI 372 certified. The tablets or the pellets are NSF 60 certified. And as I said, this is the first development in fluoridation technology in 40 years. However, I do want to point out that right now this technology has not fulfilled the requirements per DNR standards. So we are currently working with them to make that available to public water systems. So dental fluorosis, this is a condition that causes changes in the appearance of tooth enamel. It is caused by taking in too much fluoride over a long period of time when teeth are forming under the gums. Children 8 years or younger are at risk of developing that in their teeth because their teeth are still developing. They're losing their baby teeth. Permanent teeth are coming in. The severity of dental fluorosis depends on how much and how long and when you took in the fluoride levels. So most dental fluorosis in the United States is very mild to mild. It may appear as white spots on the tooth surface or frosty edges or lacy chalk line-like lines that are barely noticeable and do not affect dental function. Moderate and severe forms of dental fluorosis cause teeth to have larger white spots, and in rare severe form, rough pitted surfaces. Dental fluorosis does not occur from community water fluoridation when it's at the optimal level of 0.7 milligrams per liter, or if it stays within that recommended range of 0.6 to 1.0 milligrams per liter, even when it's coupled with other fluoridated over-the-counter products, such as toothpaste, mouthwash, or fluoride treatments that occur at the dentist office or at schools through our preventive service program. The current occurrence of advanced severe fluorosis is close to zero in areas where the fluoride level in drinking water is below the secondary maximum contaminant level of 2.0 milligrams per liter. So this is just a picture of what you might see with fluorosis. So this was mentioned in the comments that when there's too much fluoride maybe being ingested through toothpaste. So toothpaste effects are mainly topical, but it is definitely swallowed by some children and becomes available systemically because of that. So it is important to make sure that kids are not swallowing toothpaste, that they're spitting it out, and you only need to be using a pea-sized amount when you're brushing teeth. So, and these are just some of the ways that fluoride is delivered here in the United States, and the concentrations it's delivered at and how it works in your body or on your body. So tooth decay prevention is, so the best prevention for tooth decay is frequent exposure to low concentrations of fluoride in water fluoridation and fluoridated toothpaste. Okay, just a few more slides and then we'll wrap up, guys. So Tracy mentioned some training opportunities through the CDC. Office of Dental Health does have a training opportunity available that is approved through DNR for CE credits for water operators. This was developed in conjunction with the University of Missouri College of Engineering. It is a 1-hour free online training that you can take as you want, as you have time to do it. And it, as I said, it is approved for 1 hour of continuing education through DNR. So as Tracy mentioned, we did obtain for Missouri the approval through DNR for the fluoridation learning online training offered by CDC. So you are able to take that training and receive 8 continuing education hours for water operators. However, it is an all or nothing. So you do have to do all 4 modules, which takes about 6 hours if you do it all at once, but you can definitely do it over a time period so you don't have to sit down in one day and do that. Once you have completed that, you will need to contact the Office of Dental Health on how to get your CEs awarded, because since this is an online training through CDC, DNR did not associate a training class number with it. So the CDC website has a lot of information on there. I would encourage you, if you have not gone out and visited, to definitely do that. And see what is out there and information about water fluoridation and how it works, how it assists people, and how it helps prevent tooth decay. So that is my time, and I'm so sorry that we ran over, and I appreciate you guys staying on. So I will turn it back over to Gary and Ashley.
Thanks, Gwen. That was great, and everybody, too much good material for us to cut it off. So I'm glad it looks like a lot of people could stay on. I do think that we had a question in chat. It was a little ways back there. I don't know, Ashley, if you have it or because I've kind of lost it in the feed.
Give me one moment and I will find that.
Okay. Wait a minute. Go ahead.
The question was around severe dental fluorosis and the factors that contribute to that. So Tracy, I know that was during your presentation.
Yeah, I saw in the chat that I think Dr. Johnny Johnson actually sent over some information, and then Gwen also ended up touching on that. The one thing that I will say, and I think the question was kind of very specific to a water system, I think had noted that they weren't fluoridating and the children were having too much exposure. There are a lot of factors that go into that, but what I can say, at least as far as the recommended level 0.7, is those exposures were all taken into effect and that factor when the 2015 recommendation was released. So we do, though, understand that there are things that are out of our control, like the swallowing of toothpaste, and also, the drinking of bottled water that, sometimes won't be listed with the amount of fluoride that they have. But I just like, and then also you said the system wasn't fluoridating, so I'd be interested also to know if maybe they had some natural higher fluoride levels as well. But I can say that as far as the 0.7 and what the target we're hitting takes majority of all of these factors into account. Gwen, did you have anything to add?
No, not really. I'd be curious to find out where the system was at, just so I could look at their natural fluoride level to see if it is a higher level, like maybe it was one of the areas in Missouri that was finally recognized that had to make some adjustments and take some of the fluoride out.
Or even too, if they might have been, if they maybe are on a private well, maybe they don't even know how much fluoride they have, that'd be something that they probably would want to check as well.
Thank you both for addressing that. I'm going to see if there's any other questions that have come in. There's not. It looks like the question was asked from an individual in Lynn, Missouri.
So was that asked by you, Larry?
I believe it was, Gwen.
I would be curious to know, like Tracy said, if the child's on a private well, because Lynn has a lot of private wells. I know that we do not fluoridate our water. So I know that there was no exposure, even by a possible overfeed of fluoride into the system, because we don't have it here. So I would be curious to know if that child was ever on a well, if they received treatments from another dentist besides the one local to town, maybe a fluoride, treatments, drops, or different things like that. But it's like Tracy said, it's kind of hard to answer that without knowing all of the factors involved.
Thank you both. That was the only question that has come in. So if you have a burning question, you still have a couple of seconds to put it in the chat, and we have the time to answer those. While you think of any last minute questions, just a reminder, the CE code for this session is effective, and that's in the chat as well. You should be receiving that CEU survey shortly. If for some reason you haven't seen it in the next few minutes, please do check your spam folder. We do have some times where the info account does go to spam. If you've checked there and you still haven't received it, you can always email us at info@oralhealthmissouri.org. Still not seeing any additional questions. So thank you, Gwen. Thank you, Tracy, for your knowledge that you shared this afternoon. The recording will be made available along with the slides, and that'll be posted on our website in the next couple of days. Again, thank you all for attending, and we look forward to our next webinar in the future. Have a great afternoon.
Thanks, everyone.
Thank you.
Bye-bye.